Thank you for inviting me to speak today, Shaq. It's been a year since we were invited to start preparing for this talk, and it's been a very interesting year because it's given me an opportunity to reflect and think about what we're going to talk about, and to talk to a lot of our patients as well about the fact that we're going to be talking on this subject. And their enthusiasm has been phenomenal. They're really excited that this talk is going to be given to explain the difficulties they have had in accessing the right person for their care. And the talks this afternoon are being filmed and they are being put on the web, and a lot of the patients are going to access the talks and look at what's being said. And they're really pleased that this is happening. Now, have you got any ideas what's not happening there?
You can't have it on.
So hopefully we can get it up and running. It'll come out in the right order. But what I want to do is I'm going to start by just giving you some background on balanced medicine in general, why it's such an important topic. Then run through, oh thank you, fantastic. Then run through some of the background issues that we're going to address. Look at the type of patients we see and we consider our own before moving on to the more complicated patients where we really do need friends and where we truly need to work as part of a multidisciplinary team. I want to touch on politics, which was a bit nerve-wracking, especially if the talk's been filmed, and move on to how we might improve our practice reflecting on our patients' experiences. Balance is a huge problem. I can throw any number of statistics at you, which I think are impressive. 3 out of 10 of us will experience moderate or severe vertigo before the age of 65, moderate or severe. 8% of the population will need to access specialist balance services at some time in their lives. And it's the commonest reason for seeing a GP over the age of 75. These are big numbers. And have a look at my county here, Leicestershire, population 1 million. 15,000 new patients access their GP for a balance problem every year. And let's put that into context of the talk that we were going to listen to just now. 13 per million will be diagnosed with an acoustic neuroma, a subject we think about every day in our otology clinics. So over 1,000 times as many patients are going to present with dizziness as with an acoustic neuroma. So it's a big subject for us to grasp and own as otologists if we're the right people to do that. And of course, the vestibular system, the labyrinthine system, is one of the principal systems that's going to go wrong in patients with dizziness and imbalance. And the 3 main systems are going to be visual, proprioceptive, and labyrinthine. But there are a huge number of other systems which will interact with that or be the primary cause of the balance disorder, and hint at the fact that we need lots of colleagues to help us with some of those problems. But we also need someone, the otologist, who has experience and knowledge of these other problems to be able to direct the patient to the appropriate specialist. Now, when we see a balanced patient, the first thing we will always teach our medical students and registrars is divide the symptoms into 2 groups. It makes it much easier. Those with a chronic instability, a chronic dizziness, which most commonly is going to be a fixed vestibular deficit and most commonly is going to be the result of a vestibular neuronitis or a labyrinthitis, and those with episodic dizziness, which may or may not result from a fluctuating labyrinthine disorder. And of course, these are challenging patients because when you see them in clinic, often they're normal. So with chronic dizziness, if you look at this lady here walking, just have a think about her gait, how you'd put that into words if you were writing it in the notes. And we'll come back to that a little bit later. Now, this lady presented to her GP, according to the referral letter, with a couple of years of unsteadiness and dizziness. Please see. Now, we all know the heart sink symptoms of the chronic balance patient. Headache, neck ache, fatigue, I just come off a boat, Malda de Barcmont type symptoms. They're all very non-specific, and it's difficult for a GP to know who to refer the patient to. So looking at that video, the GP could have referred to any of these groups of people here who would have had their own unique and individual expertise, but not necessarily the breadth of knowledge to get the right diagnosis and treatment for that patient. And perhaps we can claim as otologists that the balance clinic, therefore, is the best place for such a patient to be referred to start with, rather than after a long journey. And if we turn to episodic dizziness, even more difficult to get a diagnosis in many people, I like to teach about the 12 P's of paroxysmal vertigo. And each registrar I have through adds in a new P and an old one drops off. These perhaps are the most important 6 P's. And there's some diagnoses that might come out of these aid memoirs. And there's 2 interesting things, I think, from this list. The first is, look at this work here. Do you get dizzy when you lie down or roll over? Positional dizziness. Odds ratio of BPPV, 15. When you get your dizzy spell, are you sensitive to sound or light? Odds ratio, 41 for migraine. You've got your diagnosis, but you've got to remember to ask the question. So whoever's seeing these patients has to have the breadth of knowledge and experience to know what the correct question is. And the second point is, look at the diagnoses on this simple list. Sure, there's some ENT diagnoses, neurosurgical, cardiovascular, maybe psychological, physiotherapy, lots of other diagnoses. So lots of other specialists may be involved in these people's care. And likewise for my second 6 Ps, other potential causes we may forget to ask about. But again, really high odds ratios. Have you got poor hearing? Not even fluctuating hearing. Odds ratio of Meniere 6. Are your symptoms perimenstrual? Well, lots of causes dizziness there. Odds ratio of migraine, 8. Really simple questions, but a very high yield in pointing you towards a diagnosis. And then down in the small print, I couldn't think of any other P for that one, we have some much rarer conditions which we certainly ought to know about, and some of them, vestibular paroxysmia, maybe otologists are amongst the fewest people who'll know about that condition at all, but can be successfully treated. So who might the GP have referred that list of patients with intermittent balance disorder to? It could have been any of these people here. But they all, again, have their own unique expertise and not necessarily, in all cases, breadth of knowledge. So let's have a look at a couple of conditions that are very close to our heart. These are otological problems. We have ownership of these conditions. These are common conditions, but look at the patient journey. Look why those patients I phoned up to ask if I could use their information were so passionate about this talk being given. 10-year-old data from the UK. I'm sure we do better now in this country, but 92 weeks to diagnosis and treatment for the average patient with BPPV. Half of that time spent in the community and half seeking the correct specialist in hospital care. It's extraordinary, isn't it? Now, I'm sure with the internet they are better now, but there are lots of other conditions not so well known where the same story occurs. And the same over in the States. Here's a paper from Florida. The average patient with dizziness was seeing 4 physicians and taking 52 months to get to the right specialist, to get to the right diagnosis and treatment. And these aren't papers I've just plucked out of the air. These are the papers that were used by the Department of Health a few years ago when explaining how we ought to be setting up and running balance centres. So our patient with BPPV, well, quite a lot of them seem to be treating themselves, having read the internet. And some of them may well get themselves better. Some of them may misdiagnose themselves. But we're getting referrals from lots of different specialists. And we are essentially, as otologists, seen as the referral of last resort. If we can't get you better, go and see the balance clinic. And one of the reasons for that is that we're the only people who can operate on the ear. Surgery for BPPV is relatively small print. The very small number of large series that are out there are suggesting maybe 1 in 200 patients referred to a specialist balance clinic with BPPV will end up having surgery for it. But the surgery is incredibly simple. Any otologist can undertake this, I think, without much difficulty. And the indications are fairly nebulous because there's not much published on it, but distressing intractable BPPV over a long period of time, whatever that is. Failure to respond to standard treatments, and of course, importantly, and hopefully, adequate hearing and vestibular function in the better ear. if you're going to operate on them, they need a CT scan beforehand, and that was something certainly I was taught very early on. And knowing where the posterior canal is very helpful, because you can get what looks like just a little web of air cells here. You can get an air cell tract that actually can lead you astray, and there are reports of packing an air cell tract and missing the canal. So I would urge getting a scan if you're going to do this surgery. And likewise, basic testing, audiometry and caloric testing, to make sure there is function in the contralateral ear. Now, I've put together my experience of patients who have had at least a year's follow-up following this surgery. And in Leicester, I've done, up until that time, 26 operations, 3 of them bilaterally. And I think there's only 2 other series of 3 or 4 patients in the literature on bilateral BPPV treatment and a high female preponderance. As is well described in the literature, head injury is the commonest cause for intractable BPPV, and I think we're all aware of that. But there are a multitude of other conditions which can cause it. And look, half of the patients had bilateral BPPV. It doesn't mean that half the patients need bilateral surgery, because bilateral BPPV is much more than twice as horrid for the patient as unilateral BPPV. And just treating one side seems adequate to settle their symptoms, although the cynical may say the patients didn't want to come back for their second operation. But it's not true. Duration of symptoms. They've had their symptoms a very long time, 10 years on average, and some of them as much as 30 years. And those patients who'd only had symptoms for a few years were desperately affected in their life. The accountant, whenever she looked up and down at the screen, would spin and hadn't worked for 8 or 12 months, and whom multiple treatments didn't work on, for example. So they are patients who are desperate for cure. And the surgery is truly not difficult. This is the lateral canal, opening up the posterior canal, and you can see the membranous labyrinth within, just here. There are no crystals in that. I haven't, in any of my patients, seen crystals in there. Now, I know there are some videos going around of that, but it's not something that I've seen. We would do an Epley manoeuvre before they're put to sleep. Then all that one does is put in temporalis fascia, some bone pate, and that's it. It's not difficult. And the results have been really, really good. Meniere's disease. Meniere's disease, if we're treating that, isn't one condition. Most of your patients, our patients with Meniere's, are going to have 5 different problems that we need to address. Sure, there's the episodic vertigo of Meniere's, but 20% are going to have BPPV. A large number are going to have migraine. And of course, the symptoms are very similar at times, but both may need treating. Almost all are going to have a degree of vestibulopathy, and all will have a degree of emotional reaction. So it may not just be the otologist treating the Meniere's patient. We may need emotional support, physiotherapy support. But this is a condition, as otologists, that we have transformed the lives of so many people. We have the most grateful patients imaginable with the most simple imaginable treatments. Intratympanic gentamicin, 80% of patients not having further vertigo after a series of gentamicin injections. And now we're looking at intratympanic steroids. And a number of faces in the audience, I can see, are joining a group with a Californian company with long-acting intratympanic steroids. And we're starting that in the UK, as otologists, very soon indeed. So there's lots of exciting developments going on there. And other surgical interventions of greater or lesser repute that we as otologists can undertake. But it's not all straightforward. This is the patient we saw to start with. So have a think of her gait. I would probably describe that as fairly short-stepping, maybe shuffling gait. So the first thing we're all going to think is Parkinson's disease. But the thing is that she's walking upright, not stooped. And she's swinging her arms. They're not still. So you can get this type of gait in Parkinson's, but in fact this is termed marche à petit pas, which is a subset of Parkinson's in some people, but more often is caused by diffuse cortical disease. And this is Darwin's finger. You sometimes see an MS, and this isn't MS either. This is cerebrovascular disease, causing diffuse frontal lobe changes, causing a short-stepping gait. Now, as an otologist, you and I may not be expected to make that diagnosis, but we are the people who are going to see this patient with non-specific dizziness and imbalance. And in fact, to make it even more difficult, we're the people who see them first often now, Because when their symptoms are much more obvious, they may go to a neurologist first of all. So we need to have that breadth of knowledge to be able to say, okay, it's not vestibular, it looks neurological, see my neurologist. Have a look at this lady. She's really generously allowed us to use her phone. She's seen a large number of specialists in a significant number of hospitals. She has a background imbalance, but she's been referred in with intermittent imbalance and myoclonic jerks. We can't get the diagnosis. What's going on? And she is devastated by her symptoms. They're occurring intermittently, and they're wrecking her life. Now, I brought her to my joint neuro-otology clinic to try and identify what the cause was. And she does have a degree of underlying vestibulopathy. But what she also is terrified by her symptoms. So this is an emotional reaction to the underlying vestibulopathy. And once she was told that, what was her reaction? Thank you. I feel better. And I spoke to her on the phone a couple of weeks ago. This is a couple of years old, this video. And she's at university now, doing really well indeed. But again, as otologists, we're often seen as the last resort for these patients, and we need to have that breadth of experience and confidence to give them the right diagnosis. And I think one of the interesting things, in fact, in putting this talk together, has been going back and speaking to patients from quite a long time ago. And so often they're saying, do you know, we think of you every day of what you've done for us. And that's the same for all of us in this room. And I think sometimes perhaps we forget that. We do make a big difference for these people. Have a look at this case here. What would you have done with this patient? Now, this was a year ago, and he came to see me privately. He wasn't a wealthy man, and he'd been saving up for a number of years for the retirement trip of a lifetime. And they were flying to Antarctica, and they were incredibly excited. And they were leaving in a week. And I said, what's wrong with you? And he said, nothing, doctor. Okay. Why have you come to see me? Well, his wife said, he's just not right. He's a bit wobbly. He said, nothing wrong with me, dear. I'm fine. So I went through the whole history, an examination. I couldn't find very much. And I went through the history again. Are you sure you haven't bumped your head, fallen, anything? No. And his wife said, dear, you fell out of an apple tree 4 months ago. He said, but I only grazed myself. Well, I got a scan. That's a chronic subdural. And if you fly with a chronic subdural, you're not going to do very well at all. So he was referred to the neurosurgeons, who remarkably took him within 4 hours, and that's a record in my book. And interestingly also, he was treated with steroids. And I spoke to him a couple of weeks ago on the phone, and he's just back from South Africa on holiday, and is having a really fulfilling retirement. So we can make a difference in non-otological conditions. You have to have that breadth of knowledge to be able to see them. And how about this one? This is a chap, fairly frail, elderly gentleman, lives quite near me. I cycle past his house almost every weekend. Referred over from the physicians. And they'd said he'd got mild orthostatic hypertension. But whenever they put him in the Hallpike's position, he was terribly dizzy. And every time we do an epley on him, we don't seem to get his BPPV better. Can you see him, please? So I saw him, and I tried a couple of epleys, so I was sure mine were better. Came back a second time, same symptoms. But the thing was, when I lay him down, he said, doctor, that's it, that's what happens, that's what happens. And he nearly passed out. So I thought it was probably worthwhile taking his pulse, which fell from 80 to 20 during the Hallpike's test. So he was in complete heart block. And he was also accepted by the cardiologist within 24 hours. And I had a biventricular pacemaker. And I really enjoyed the letter from my friend and colleague, Alistair, the cardiologist, who tells me at the time of the implant, he went into ventricular standstill. Now, you need to understand the standing we have as otologists in the medical community, because he needed to remind me that his heart stopped. So we can kid ourselves we're seen in a good light, but I don't know. That's what we're dealing with. That's what we're treating. Now, let's look at the political context. Now, I was introduced to this first with Professor Ramsden and actually Richard Irving about 4 or 5 years ago. And we had some meetings with the Department of Health. And I think that everyone recognises this statue, I'm sure, from RNT&E. It's St Blaise. Now, does everyone know the fate of St Blaise? St Blaise is the patron saint of ENT and was a great Christian and a great carer of the sick. And the Roman emperor of the time wasn't terribly impressed that someone was so loved. Now, St Blaise was summoned down to see the emperor, thinking he was on for some great gong. But because the emperor didn't like the good that he was doing, he had him beheaded. There was a lesson there, perhaps, for all of us, dabbling in politics. Now, this all started back in 2008. Now, do you remember this publication from the physicians? Balance Disorders, Achieving Excellence in Diagnosis and Management. That set the cat amongst the pigeons. Another speciality was, open quotes, taking control of balanced medicine when we thought it was ours. And it's done a huge amount of good, of course, because it stimulated great interest. And Tristram Lester and Martin Burton put together the ENT UK response, and very aptly named it was too. And around the same time, the Department of Health were exploring balanced medicine in the UK and put a lot of proposals together. And there's also this other publication around that time, The Future of Healthcare Scientific Workforce, which is looking to change the way we work. And all have potential threats. But the drive from the Department of Health at that time was that balance was going to be demedicalized. It's cheaper, of course. There's a reason for it. More people can be seen. But the negotiations at that time came up with some really useful promises that are written into the book. And that's there would be a medical member of every balance team. And of course, because otologists have large numbers, there's lots of us, we are hopefully likely to be that person often. And most importantly, I think, that every region ought to have a named balance centre or balance service. So the patient journey ends where it should begin. So people are not going round a circuitous route to find their treatment. And that we really must grasp. And if there isn't a balance centre in your region, this is something I think to think about setting up. And also, of course, complemented by a falls clinic. And this is the ENT UK position, where those who have obvious cardiology maybe or neurological problems get referred over, triaged over there, and there are different levels of balance service offered in different hospitals. The balance clinic, as Shaq has said, evolved over the last decade or more. And my predecessor, Jim Cook, brought the idea over from Washington University, where he'd met Joel Goebbels. And we've developed the service from about 3,000 patients a year a decade ago up to 5,500 appointments a year now in the Balance Clinic in Leicester. And we have satellite clinics out in the community as well. And we're trying to get all patients with balance disorder referred either into the ENT-led balance clinic or the medically-led falls clinic as appropriate. And we're trying to concentrate expertise and facilities. But there are ways we can make the service better. And one of them, and if you're not doing this and you're running balance clinics, I'd urge you to do, is think about setting up joint clinics. Not only are they fantastic educationally, and I've learned so much in these clinics I've run over the last 10 years, but they're great fun as well. And you get a really good clinical network. And we have audiologists, physiotherapists, scientists, and so on, working in parallel in the clinic, and likewise in community clinics. And for out-of-region patients, we try and run one-stop clinics, but we've found it very difficult doing that for local patients because of volume of work. We've also, because this is a truly multidisciplinary speciality, tried to set up networks of specialists so we get to know each other. And so one of my colleagues, Dil Lakhani in the Falls Clinic, and I set up Spin Doctors. And we've got members covering a very wide range of specialities who might see balanced patients. It's an informal group. We don't meet in the hospital. We meet out of the hospital every 2 or 3 months in the evening. And one of us will give a lecture for an hour, hour and a half on their area of interest. Now, how often have we had a lecture on tilt table testing or cardiac dysrhythmia? Probably not since medical school. But actually, that's what our patients need. And learning in an informal venue like this is great fun, and you learn a lot from each other. And we've now taken this far enough, having gone through a loop of these lectures, to try and take our service further. So what we're putting plans together now, business plans together now, is to try and set up an integrated balanced service, which we hope will be the next thing. And we've got lots of bits of it in place. Sure, we've got the Balance Centre, we've got our team, joint neurotology clinic, syncope service. We've even got a dizzy gynecologist, and he's really good. He is really good, Farouk Al-Azawi. For our ladies who have perimenstrual syndrome, you know, we can treat the migraine maybe, we can treat perhaps perimenstrual Meniere's disease, but actually it's probably better regulating their hormonal cycle. And he is a very bright chap, and he does it for us. So getting a network of friends is a really good start. And then what we're trying to do is to get a single referral point for the whole county. Not, is it falls, is it syncope, is it neurology? All come in to our specialist integrated balance service, and we will triage within one unit. And we'll have all of our work within one unit. So the falls physiotherapists and the vestibular physiotherapists and our joint clinics and the falls clinic and the balance clinic are all in one area. Our scientists are there, our investigation tools are there. So I think doing this and working ever more closely with colleagues and yet leading the service will offer a much quicker and more secure route to diagnosis and treatment for our patients. And they can even have several appointments around the loop on the same visit, rather than huge numbers of appointments over a very drawn-out period. And I think it'll be efficient as well. We have a role in education. The balance course we run in Leicester, we've had 400 or 500 delegates in the last 10 years, but look at the range of specialities that come to the course. We really preach a multidisciplinary approach to the balanced patient. Everyone's equal in the team. Everyone can contribute equally to the team. And similarly in research, this is maybe not where we're always strongest in the UK, but the British Society of Neurotology was founded by Adolphe Bronstein, Professor of Neurology at Charing Cross, and he's still president. But it's an area where people from all sorts of different backgrounds, not just otology, not just neurology, present their research ideas. And learning what people are doing from other backgrounds is incredibly stimulating. They're ideas that we haven't thought of. And again, as Jacques said, I'm chairing that now, and Professor Bronstein, as a neurologist, is still life president, but we've got people from around the world on the committee and from multiple different backgrounds. And integrating ideas, integrating specialists, has to be the way that we can take the speciality forward. So to conclude, having a dedicated balance unit, one centre for referral, is going to be the best place for our patients to be seen. It's most likely to be led by an otologist. We're the people who can treat from beginning to end, the only people probably in some cases, and by dint of the numbers of otologists in the UK as opposed to other specialists, it's likely to be an otologist who's doing this. But we need the help of our colleagues in a multitude of different disciplines to give our patients the best care and the care they deserve. For them and for us professionally and academically, it's enormously fulfilling working with people from lots of different backgrounds as well. Thank you.